Thanks, Becky. That was a great talk. So now we're on to some debates. I will be debating Howie Herrmann, so God help me. He's smarter than me, but I'm funnier. Okay. So I was asked to say that tricuspid replacement, will be the predominant therapy for transcatheter tricuspid intervention. So we've got lots of subtypes of TR. We've got atrial and ventricular functional, lead-induced, and primary. So the question is, can one device treat them all? So here's a snapshot of the current tricuspid intervention device landscape. You can see we've got replacement, edge-to-edge, annuloplasty, heterotopic valves, spacers, and I hope to convince you that valve replacement will become the predominant technique for many reasons, and that repair, particularly edge-to-edge, will be in selected cases only. So this is a landmark study. The PI is sitting here with us. This was the first attempt to understand, does doing anything for functional TR, mainly functional TR, with a catheter improve outcomes compared to diuretics? So we learned that TriClip, G4 mainly, and some G3, can get you to moderate TR 90% of the time, which is really better than we've ever done in a core lab adjudicated study. However, only 50% of patients got to mild TR, which I would argue should be the goal, just like it is in MitraClip. So the primary endpoint was in favor of TriClip, mainly driven by improvements in quality of life with a KCCQ improvement of 12 points. But as we've heard, there was no difference in the hard clinical outcomes of mortality and heart failure at 1 year of follow-up, and 5-year follow-up is planned. So the important observation is there's this clear dose response between TR reduction and improvement in quality of life. And as Paul's already mentioned, it's very clear that as your quality of life improves, you start to likely impact some of those heart outcomes that we care about. So why was Triluminate a negative? Well, as we've discussed, we didn't really know who we were enrolling, but we ended up enrolling somewhat healthier patients than the ones that we get referred to treat in places where the device is commercially approved. Like while I'm sitting here, someone's texting me WhatsApp images of the tricuspid valve with ascites, recurrent heart failure, if they lost 20 pounds. Those are the patients that were being referred to treat with TriClip. So a lot of patients were class 1 to 2, not a lot of HFrEF, not a lot of heart failure hospitalization at baseline, and I would argue not enough TR reduction to see the effect that we wanted to see. Now, there is 5-year follow-up planned, but there's crossover at 1 year, which may dilute the results. But this was an excellent first trial, and it's a landmark study. The current trials, which are ongoing and some are completed in Europe, hopefully will provide some further answers in a sicker patient cohort. So part of the reason that we have variable results with tricuspid TR is the variability in anatomy, and Anita very eloquently outlined this, but you know, this analysis suggests that when you have more than 3 leaflets, then the results are not as good because it's harder to choose which leaflet pairs to join together. You may distort things. It's kind of like a chess game, and chess is fun, but you don't always win. So we know residual TR predicts clinical outcome. TR is bad for you, particularly when it's left to be severe or greater. It does impact heart failure and death. And so I'm left wondering, is moderate TR good enough? The surgeons have taught us that surgical repair for the tricuspid valve has limitations, mainly recurrence of TR, and thus the promise of tricuspid replacement. So here's a snapshot of all the valves that are being studied. There's at least 7 valves in various phases of clinical trials. And then we also have the heterotopic valves and spacers, which are for the patients that you can't treat with any other device. So if we focus on the EVOQUE valve, which has the most evidence behind it, it's now available in 4 sizes up to 56. It's transfemoral percutaneous 28 French. And as Becky mentioned, you do have to have leaflet capture with the anchors, which is guided by echo. So in Toronto, we had the privilege to do the first in-human transfemoral TTVR with EVOQUE more than 4 years ago, and it went quite well. As you can see, we've largely abolished the TR, It took us about 2 hours. And the initial compassionate use experience was very favorable. There was 0% mortality, very low rate of complications for compassionate use experience, but there was the signal of pacemakers, which has persisted to today. But as you'd hope, the TR is basically gone in 90% of patients. And so then we had the TRISCEND-1 EFS, which with a core lab confirmed that we abolish TR when we use a TTVR such as EVOQUE. 98% of the time it's mild or less. And so, the company was fairly ambitious to quickly move to a randomized trial. There's a lot of centers that are in an early learning curve of tricuspid intervention in general, but they pushed forward and the trial is now fully enrolled. So this data was presented by Sushil Kodali at TCT a month ago, and so the trial design is 2-to-1, EVOQUE versus medical therapy, and what was presented was the first 150 patients, 6-month outcome. And the total cohort of 400 patients will be presented sometime next year. So these patients are elderly female with AFib. For some reason, the randomization was not totally equal. There's an excess of stroke in the EVOQUE arm, but aside from that, you can see they're well balanced. 40% of patients with pacemakers, which really highlights how often pacemakers cause TR, and 60% of the time, patients have massive or torrential TR. So the safety endpoint at 30 days, mortality was 3%. Severe bleeding was 10%, which is less than we'd seen in the TRISCEND-1. And the need for surgery, mainly for RV wire perforation, was 2%. Pacemakers come in at 15%, and so overall, the safety is looking pretty good, given this relatively early experience. As expected, the device abolishes TR based on core lab, and importantly, the quality of life is improved by 18. Now, this compares fairly well with other trials such as COAPT and some of the partner studies, and if you believe the data that KCCQ correlates with mortality, then you can read the tea leaves for what this trial may show at 1 year. So on the basis of this data, the device got CE mark. This is now available off the shelf in Europe, although I would say the rollout is going to be very controlled. And what we've learned so far about TTVR, we abolish TR almost all the time. These are fast, reproducible procedures, a lot like TAVI, a lot less like CLIP, less reliant on procedural imaging. This is somewhat device-specific. And you can treat almost any pathology, huge gaps, tethering, leads, carcinoid, rheumatic, it doesn't matter, as long as the annular sizing is suitable. The cons, of course, are safety, so bleeding, pacemakers, durability, subsequent valve-in-valve, we have to learn, and screen failures actually have come down. So here's a suggested patient and device selection algorithm. You can see there's our overlapping Venn diagrams. I'm going to argue that 2/3 of patients are going to be more towards replacement and 1/3 repair. And I'll finish with this, Howie. These are cases from my practice. Case on the left, I sweated for 3 hours. I placed 3 clips. I was left with severe TR. I didn't really understand why, but apparently I didn't choose wisely. And the case on the right was 30 minutes, no TR, and 3 cases done by 3 p.m. So I would ask the audience, what would you choose if you had these devices in your lab? So in summary, TTVR has demonstrated superior efficacy, acceptable safety for treatment of broad population of TR. I think it will become a frontline intervention, but we need to improve the safety. And the 1-year results of the ongoing TRISCEND-2 and the ongoing TIER RCTs are eagerly anticipated, and I think will change practice. Thank you.
Well, thanks. I think you did get the easier side of this debate, Neil, so there should be like a handicap here for me that I should start with a few extra points. But okay, there's slides showing up somewhere. Okay. So I have the task of convincing you that repair could be or will be the predominant transcatheter therapy for TR. Sorry, those were my disclosures. So we know from the MR world that surgical repair beats replacement for MR. And the question that I'll start with is, why won't this also be true for tricuspid regurgitation? And indeed, if you look at some of the surgical series, we don't have good randomized data, but we do have some matched cohorts here on the left, and also this from a large prospective multi-center international registry. You can see that repair does have a better survival than replacement for mitral disease. And we know also that in the mitral world that there is greater freedom from valve-related complications. Well, what are those complications? There's better preservation with repair of ventricular function, and there are fewer incidences of thromboembolism, endocarditis, and major bleeding. We have some data in the TR world that is similar for tricuspid repair versus tricuspid replacement surgically. And this is a nationwide cohort study comparing repair and replacement, showing, again, lower mortality with repair than with replacement. And then here in a large meta-analysis, similarly, operative mortality was less for repair than for replacement, and late mortality also trended better with repair. So the question is, why isn't that true to date with the transcatheter approaches? Well, Neil showed you this data from TriIlluminate. We didn't achieve the same reduction in TR that we might be able to achieve with replacement. And for that reason, possibly, we had an improvement in KCCQ score, but not in mortality or hospitalization for heart failure. But there is a correlation between the reduction in TR and the improvement in quality of life. And the patients with the worst quality of life had the greatest improvement, and the number of patients who were alive and well at 1 year were better. And at some recent data shown by Paul and at TCT did show in this exploratory analysis that if you had a good change in KCCQ score, your event rates were lower for death and heart failure hospitalization. So the trend and the conclusion that one could draw from TriIlluminate is not that it doesn't reduce TR sufficiently, but that if you do reduce TR sufficiently, you might be able to improve mortality and heart failure hospitalization. So in the debate of repair or replacement, we can repair anything. As it says here, please knock hard on the door, the bell doesn't work. This must be somebody who got repaired in your shop, like that case you showed us, Neil. But replacement, as we all know, can reduce TR better than repair. But replacement, and therefore replacement will always beat a bad repair for TR reduction. But there are long-term valve complications that could limit the effectiveness of replacement. Thromboembolism, endocarditis, bleeding, and a potential adverse effect on RV function from putting a large valve, large space-occupying device into a sick right ventricle, changing the flow patterns through the RV. We don't really know much about the long-term implications of tricuspid replacement compared to repair. And other limitations, including the need for oral anticoagulation in up to 20% of patients who are not already in AF, and the need for a new permanent pacemaker in the TriScend study that was up to 15%, two complications that we don't have with repair. And then finally, most TR is functional and associated with annular and RV enlargement, and there are a lot of devices for repair that are not TriClip. And they include the one that is the surgical predicate for tricuspid repair, which is annuloplasty, direct and indirect devices. We have some data on Cardioband showing that that works, and there are a number of other devices as pictured on the last slide. So my conclusions are that repair is better than replacement in MR, and likely will also be better for TR, with better preservation of RV function, fewer valve-related complications, and there is some support for this from the surgical TR repair literature. Transcatheter tricuspid replacement reduces TR better than edge-to-edge repair, but data on long-term outcomes with replacement are lacking and include all these unique risks that we've talked about, from thromboembolism to infection to new bleeding risks and new permanent pacemakers. Transcatheter repairs that are more efficacious, particularly those that include or mimic the surgical standard of annuloplasty, are needed and promising and not yet in pivotal trials. And I think if we have safe and effective repairs, they will turn out to be preferable to replacement. But individual anatomic issues will always remain a prime consideration as we consider every possible option for our patients. Thanks.